We're going to talk about the use of PD for AKI, sort of a reawakening. They have no relevant disclosures. So I'm going to start by giving a little background on AKI. There's been an increasing frequency of dialysis requiring AKI, as shown in this slide from a paper published in JASN 2 years ago. A dramatic increase. This is not just the hemodynamic kind of AKI where the creatinine bumps 0.3 or 0.5. This is dialysis requiring AKI. And what's so important about this, if you look at it, if you break it down by age, you can see that the rising incidence occurs primarily in the aging population, the population over the age of 65 to 74, as you can see on this slide. And the reason that's of such concern is the population is aging. This is the US population, the number of people over 65, number of people over 85. And if you look at where we are now, that slope is going up dramatically. So the number of elderly people in the US and in Canada is going to be increasing dramatically. These guys have a very high incidence of AKI. So the burden of care for patients with AKI requiring dialysis, again, this is not the hemodynamic AKI with a small bump in the creatinine, is going to increase dramatically. And a challenge for all of us then is how we deal with and manage these patients. So let's shift and talk about PD for AKI. So what I'm going to try to convince you in the next 30 minutes is that PD has not been utilized for AKI in recent years, and I think it's something that we should really be thinking about. So 30 plus years ago, for those older nephrologists in the audience, PD was the standard treatment for AKI. That is, someone came in with acute kidney injury, they needed dialysis, you would take a trocar, put a PD catheter in, dialyze the patients as long as they needed. They recovered renal function, you took the catheter out, and that was it. But this changed when central venous catheters were introduced, and this occurs sort of in the late 70s and early 80s. And then there was a proliferation of extracorporeal therapies and devices, and PD basically almost disappears from its use for treating patients with AKI. And the death knell was this paper in the New England Journal that occurred in 2002. And this is a randomized trial from Vietnam, prospective randomized trial comparing 70 patients with PD and hemodiafiltration. Protocol was interrupted because of higher mortality rate in those patients treated with PD. But this paper is really terrible, and it's surprising it actually got into the New England Journal. It's bad because the PD was done with a trocar, not with a cuff catheter, and in truth, cuff catheters were the standard types of catheters used at that time. The infection rate was very high, and the patients treated with PD. You wonder about the techniques which used, etc. But this was really the death knell. When this paper came out, that was it for PD for AKI. But the truth was, at the same time, a paper came out from India in KI in the exact same year in 2002. And this was a randomized trial. Now, this also was a flawed study in many ways. They were simply comparing automated PD with tidal PD, and automated PD with standard conventional automated PD. In 87 patients with acute renal failure who had mild to moderate hypercatabolic states. And it's not worth going into the details of the paper, but if you read their conclusion, they concluded that both types of treatment are reasonable options for mild to moderate hypercatabolic acute kidney injury. And I highlighted in yellow what was the dose of dialysis was used, because I'm going to keep coming back to this when I talk a little bit later on. And if you look in these studies, they used a dose of dialysis with standard PD of a weekly KTV of 1.8 and with tidal PD of 2.43. So just keep that in mind, and I'll come back to this later on. But when I was a visiting professor in Chennai in 2013, there was this large picture of Demetrius Aureopoulos sitting in the waiting room of the renal section. And they were doing incredible numbers of PD to treat patients with AKI. They treated 1,000 patients a year using a traditional trocar technique, not a cuff catheter. They report rare bowel perforations and great results, but they've never published the data. They've never tabulated the data. I sort of encouraged them to try to put this together and get it out, because it would be a major publication, but nothing seems to have happened. But again, in many places in the developing world, PD is still used as a standard treatment for AKI, and very little of this has actually made it out into literature. Except that PD starts to resurface in the literature in a series of publications that come from Brazil, and they're done by Daniela Ponce Gabriel, and her name, she gets married along the way, and her name changes, so the paper is either by Gabriel or by Ponce. But the first paper comes out in PDI in 2007, and this is using high-volume PD for acute kidney injury. And she was simply exploring whether this was something that was feasible to do. And in this study, she treated a group of patients who were in the intensive care unit. And what's important about this, they have very high Apache scores. So the Apache scores mean that these patients are very sick. And in fact, they're not different than the types of patients we would see in the US or Canada. I mean, acutely ill patients requiring dialysis. What she opted to do, for reasons that are not clear to me, use very high volume PD. So she used 36 to 55 liters of dialysis solution per day using a cycler and targeting a very high weekly KTV of 3.8. And she thought the results here were acceptable. And because of that, she goes on then and does a randomized trial comparing high volume PD with daily hemodialysis for the same series of patients and publishes this paper in Kidney International in 2008. So this is a randomized trial of 154 patients, nicely done study, high Apache scores. Again, these people are not different than the kinds of patients we all would be seeing in the intensive care unit. Mortality rates are shown on the upper left-hand panel. They're identical, but a 50% mortality rate. But if you look at table 2, and this is the part that's really interesting, in the box I've highlighted what I think are the significant findings. The treatment duration was less in the patients getting high volume PD, and the resolution of acute injury occurred more rapidly in this group of patients. So that's sort of a really crucial finding in this study. Mortality rates are the same, recovery of renal function is the same, but there's less dialysis required in the patients receiving high volume PD. Complication rates are shown here in terms of infection and mechanical complications. They're not different in the two groups. So then Daniela goes on and publishes another paper now in PDI, which is looking at, in advances in peritoneal dialysis, comparing high versus lower doses of PD. And again, for reasons that puzzle me, the low dose PD is really extremely high dose. It's a 0.5 KTV per day, which is a 3.5 KTV per week. The delivered dose turns out is 4.13 in the high group and 3.43. This is a weekly KTV in the lower volume group. And the outcomes are basically the same, and it then concludes that perhaps you don't need such a high dose. But again, why such a high dose was used remains unclear. Her last paper is one that's published in 2012 in C. Jason, which summarizes results from Brazil over the preceding 3 or 4 years. There were 204 patients with AKI treated with PD. The prescribed dose is shown there, which was high. Delivered dose was about 0.5, a KTV of 3.5 per week. She's using 16 to 22 exchanges per 24 hours. And the results, again, are what I sort of described, are typical for what you'd see in an intensive care unit, and complication rate is relatively low. So then we went on and did a systematic review of all the papers comparing PD with extracorporeal therapies. And this was published in C. Jason in 2013. So the top part, Part A, are cohort-based studies, and the bottom part are the randomized trials. Now, there are only 4 randomized trials which are shown there. The first one by George has an extremely high mortality rate. The one by Fu is the one from Vietnam that I showed you. Then there's the one from Gabriel. And the first one is from Nigeria, and there's a very small number of patients. But if you look at the data, there really appears to be no difference in the cohort-based studies or in the randomized trials, which I've shown on the slide here. So our conclusion from this was that the results from PD for AKI are probably not different than they are with extracorporeal blood therapies. And this is confirmed by a study which was presented at the Arab nephrology meetings in December this year, and it's not been published yet, so I didn't include it in the previous slide, but I've actually looked at the data and spoken to them, and it seems to be a very well-done study. So this was a randomized trial comparing PD with CVVHD in critically ill intensive care unit patients in Saudi Arabia. And what they're describing is a better survival and shorter duration of dialysis in those patients treated with PD, and about 65 patients in each group. And from what I can see, the study looks very good, and we're just sort of awaiting this to be submitted for publication. But again, what I want to emphasize here, a shorter duration of dialysis, which is similar to what Daniela found in the studies in Brazil, and here they found a better survival rate. So this, again, would confirm what I just covered in the previous slide, in terms of if this were added now to the meta-analysis, it would add weight, perhaps, to the conclusion that there are no differences in the outcome from PD for AKI compared to extracorporeal therapies. So this dose becomes a big issue because Daniela targeted these extremely high doses. The guys in Saudi Arabia, the dose is much lower. It's a weekly K2V of about 2.3 or 2.4. It's not clear exactly. It's in that sort of range, so it's a much lower dose than Daniela described. So let's talk a little bit about this dose because this, to me, is really very important. So we published a paper which we reviewed in 2010. I did this with Claudio Ranco's group. Looking at it, again, it was a review of what we thought was going to be the adequate dose for PD for treating patients with acute kidney injury. And there was really not good data. And our conclusion was that the data support a target, a limited. It might be reasonable to suggest a minimum weekly standardized KTV of 2.1, and that a higher clearance should be considered if the patient is markedly catabolic. And I want to go through how we came to this conclusion. So bear with me, and I hope you accept our arguments, but you may or may not, but at least I'll go through with you how we did it. So when we look through the data on studies that reported outcomes of PD with AKI, you can see here that the standardized KTVs are measured in very few studies. The three studies in which, the top ones which are mentioned, by Ponce and Gabriel, that's that same group, and they're targeting this extremely high KTV. The one that's lower is the study that I showed you by Chitalia from India, where the KTVs were between 1.8 and 2.4. But the other studies don't really report the dose of dialysis. You can't draw any conclusion from that. So then went back and thought about what's a dose of dialysis and that you should use to improve outcomes. So if someone has AKI and is not dialyzed, they have a survival rate of 0, right? If you dialyze and the survival rate improves, and then you reach a plateau from which you don't get any further improvement in outcomes, which is shown on where the graph levels off. But then you're going to see a variation in survival rates based on patient and practice-dependent regions and variability, right? So now you have to go back on this classic paper by Casino and Lopez, which talks about this equivalent urea clearance, which is now thought about as a standardized KTV. And this is an argument made on a statistical modeling where they compare intermittent dialysis therapies to those of a continuous therapy. So the PD is a continuous therapy, basically. Intermittent hemodialysis is a variable therapy, which is not continuous. So they convert, for example, if someone has a standardized, an equilibrated KTV of 1.2, and you go up follow that arrow going up, and then you go across, that's equivalent to a standardized KTV of 2.1. So someone on hemodialysis, and this is why when someone is on intermittent hemodialysis, we target a KTV of 1.2 3 times a week, and that's equivalent to a standardized KTV on PD of about 2.1, and that's what's shown here. So let's go back now and look at the lessons we can learn from hemodialysis and CVVH. And I'm just going to refer to really two articles from Paul Polevsky's group, and he's at the University of Pittsburgh. He does a lot of work with CRT. So he's reviewing the data on CRT, hemodialysis, AKI, and the doses of renal replacement therapy in this review article in CJASN in 2010. So he reviews 8 trials. He looks at high versus lower doses of therapy. And I don't want to go through the details of this, but his conclusion is that higher intensity renal replacement therapy does not reduce mortality rates or improve renal recovery among patients with AKI. And this was for both hemodialysis and CVVH-D patients. Okay, and if you've not read this article, it's sort of an important article to read. And this is the data which is shown here. And if you look at the studies with a JADID score, which if they're low, less than 3, are really not very well done studies. You can see that there appears to be an improvement in outcomes with hemodialysis. But if you take only the studies which have a high JADID score of 3 or over, there really is no difference in outcomes. So this was the basis of the conclusion from that paper. They then do a follow-up paper in HAKD in 2012, and they're looking at CRT hemodialysis again in AKI, and they look at very high effluent rates, and they conclude that CRT effluent rates greater than 20 to 25 are not warranted for most patients. That is, the floor of the dosing range for CRT is not well delineated, but the argument to use a very high dose CRT hemodiafiltration is just not warranted. And for hemodialysis, they make the same conclusion, basically. So looking at that, we then go back and look at what the doses should be when we're looking at PD. So let's first talk about what are the doses for PD in patients with end-stage renal disease. So the minimal delivered dose of K2V should be at least 1.7, and this is based on the international guidelines which were established by ISPD and KDOQI. And importantly, there's no evidence for improvement of outcomes with higher doses of dialysis. And we'll talk about this more tomorrow morning. So the 3 studies that have looked at this all come to the same conclusion. People do well with a K2V up to 1.7 to 2. Getting doses over 2 does not result in an improvement in outcomes. And again, I'll go through this more tomorrow. So let's go back now and look at where we are with the AKI model again. So the Pilevsky's article was conclude that HD, the floor is a K2V of 1.2, 3 times a week or every other day. For CVVH, the floor is uncertain of what the dose should be. But importantly, there's no evidence of improvement driving up much higher doses than intermittent hemodialysis 3 or 3.5 times per week. And there's no reason to use very high effluent rates in CVVH because there's no evidence that it really improves outcomes. So if we make that argument, it would make sense that if you use intermittent hemodialysis 3 times a week, you really should target a K2V of 2.1, and that's where the target should be for treating patients with acute kidney injury. And that's how we came to that conclusion in that paper. The Brazilian studies target a much higher dose for reasons that I don't understand, and I've talked to Daniela about this, and I would love to see a randomized trial using lower doses. And again, the Saudi paper, I hope it gets published soon, uses a much lower dose. So then, again, that goes back to this paper. We looked at this and we came back conclusion that the targeted K2V should be that of 2.1 for patients with acute kidney injury getting PD, but that a higher clearance should be considered if the patient is markedly catabolic. They might perhaps need a higher dose of dialysis, perhaps approaching what Daniela was able to do. So now, the question be, why should we even be talking about this? Why should I be talking about this at this Canadian meeting, and why should me as an American be talking about using PD for AKI? So I'm going to give you 4 reasons why. First, both the Brazilian and the Saudi papers that suggest that there's a shorter duration of dialysis with PD compared to extracorporeal therapies for acute kidney injury. Secondly, the studies by Chris McIntyre, who's now in London, Ontario, have done these fascinating studies emphasizing the hazards of hemodialysis in terms of myocardial, cerebral, and GI gastrointestinal toxicity. These issues he's raised, the ones that had myocardial stunning, the ones that had cerebral injury from cerebral hypoxia, and the idea that you have gastrointestinal ischemia and transbowel migration of endotoxin, for example. So those studies are fascinating. So the argument really would be that hemodialysis used intermittently is not as benign as we think it is, that you can get myocardial, cerebral, gastrointestinal damage from this, and you really can aggravate patients who are critically ill and worsen their condition. This would not happen with PD because you have less hypotensive episodes, less periods where you're having rapid fluid removal. Next reason is PD outcomes have gotten dramatically better over the last several years. And I'm going to talk about this tomorrow morning. So PD outcomes, when you look at the USRDS database, has had a dramatic lessening in mortality and improvement in technique survival rates. And we'll discuss this tomorrow morning. And fourthly, there are lessons from PD for its use for urgent start dialysis that we should think about. And lastly, it's not on this slide, there are lessons that we can learn from the developing world about PD's use for AKI. So this is reverse now. Rather than us in developed countries teaching the developing world, we should look at what the developing world is doing, and perhaps we can learn from them. And that's what I'm going to talk about in the remainder of the talk. Let me skip this. Okay, so this I want to talk about. This shows the decline in mortality rate over time from the USRDS database. The PD is shown in the orange line, the hemo is shown in the yellow line. And you can see there's a really dramatic drop, more dramatic drop in PD outcomes than there are with hemodialysis outcomes. PD is getting better and better. And I'm going to talk about this tomorrow morning. Okay. Urgent start PD. I know this is a subject of a talk coming up, but I want to mention this because I think we've learned a lot from urgent start PD, and this is applicable to the use of PD for AKI. So urgent start PD is something that everyone, I think, has gotten very interested in for a variety of reasons. And again, this was covered in this interesting paper by Ashu Ghaffari in AJKD 3 years ago, where he talked about this urgent start use of PD. So this is for patients who come into the ED, for example, who are uremic, who need to start dialysis urgently. Traditionally, we put in a central venous catheter, put them in hemodialysis, but we shifted now, and now many places have shifted, and are putting in PD catheters. And the lesson we learned from this is you can put in a PD catheter and use it right away. This traditional model of putting in the catheter and waiting 2 weeks to use it, turns out you don't need to do that. You can put the catheters in and use them right away. And I think this will be covered by the next speaker. But the driver for this was Jeff Pearl's paper, again from the Canadian Registry, looking at outcomes with hemodialysis and how the access varied, impacted on the mortality rates. So this is a study looking at survival curves by modality and access type. And you can again see, which is very obvious, that patients who start hemodialysis with a central venous catheter have a much higher mortality rate than those patients start with PD or HD with an AV fistula or an AV graft, and this is correcting for the usual variables. So the idea that putting in a central venous catheter and starting people on dialysis is the right thing to do really doesn't hold up, because they are in fact going to have a higher mortality rate. And you can put in a PD catheter and you can start these people on PD, and the catheters can work well right after they're put in. So the model has really shifted, and many centers have really shifted to this urgent start PD. And the reasons for the central venous catheters and having a bad outcome is severalfold. One, obviously the risk of sepsis is there, but this is a paper from the CHOICE study, and really just look at the upper left-hand panel and looking at the change in CRP levels in those patients who are, this are incident patients starting dialysis with an AV fistula, an AV graft, or a central venous catheter. There's a marked increase in CRP levels in those patients that start with a central venous catheter. So the higher mortality rate with the central venous catheter relates not simply to the problem of sepsis, but this, I think, to the problem of inflammation and stimulation of inflammatory markers. And at least in the US, and I think it's probably higher in Canada, about 60% of patients who start dialysis start with a central venous catheter. This number is starting to drop now, according to a most recent publication that just came out in JASN, I think. But it has been up around 60%, and maybe down to about 50% now, but it's probably not much below that. All right, so let's turn to PD in the developing world. This is an area that I've been very interested in, and Karen Yates has as well. But I think there are lessons we can learn from the developing world. So I want to run through the data on where that is, and I'll then try to come back to how this applies to the US and Canada. So the Saving Lives Project is a partnership developed between the Sustainable Kidney Care Foundation, the ISN, the ISPD, and IPNA, with a 5-year grant from the Kaplan Foundation. The 3 international organizations are responsible for training individuals on site or funding individuals to go to centers for educational purposes. SKCF, the Sustainable Kidney Care Foundation, has the funds to purchase PD supplies. And there's an SYL project that's coordinated by a steering committee, which is shown here. But the model is the following, that we train doctors and nurses from regional health centers, and we train them in the developing world and train them in the basics of acute PD. We then follow this up with a CME program sponsored by the 3 international organizations to support educational missions in the region. We provide free supplies for the first 1 to 2 years, but we try to get a commitment from the hospital to purchase supplies by the 3rd year. We try to partner with university global health programs or NGOs or government organizations to provide assistance. We will not provide funding for dialysis after 30 days. So patients that don't recover kidney function after 30 days are sent home to die because we can't commit to providing long-term care for patients. And 99.5% of patients should recover within 30 days. And we prefer cuff catheters, commercial PD solutions, using a modified CAPD technique, not automated PD, because you want to keep this simple for the developing world. So then when we started these projects, we thought that we actually needed to develop guidelines. So we formed a group from really an international group and many people from the developing world. The group is shown here, and we published these guidelines for treating AKI with PD and PDI. This came out in the summer of 2014. But let me just focus on what are the key findings from these guidelines. First, that peritoneal dialysis should be considered a suitable method of renal replacement therapy for patients with acute kidney injury. And the proof of principle is shown in this study that was published from the Sudan. It came out at the same time, the same issue really, that the guidelines came out. And Sudan, it turns out, has a very well-developed dialysis program. The government provides funding for hemodialysis units, and for PD, they've got an experience now with several hundred patients on peritoneal dialysis and currently manage 100 people on PD. But they use PD really for AKI, and this is a study that was published in PDI. 659 children with AKI. The majority who needed dialysis were treated with PD. Recovery from AKI was about 70%. Death rate was 30%. 6% went on and got CKD. So the idea of using PD for AKI in the developing world really works, and this was a very nice paper to complement the guidelines which we published. We felt that you should use flexible PD catheters, which should be cuffed. The catheter should be tunneled. The method of implantation should be based on patient factors and local availability and skills, and that the PD catheters should be inserted by the nephrologist because it's safe to do this. So we've now demonstrated that you can train nephrologists from the developing world, even those folks who have no background in nephrology, just general internal medicine. If we can send them to places, train them, they can come back and put in PD catheters. And I'll show you the results of this in a little bit. And we preferred using a closed system with a wide connection device to decrease the risk of peritonitis. So again, we want to use the cuff catheter shown in the lower left. The old-fashioned trocar catheters shown on the upper right are really not good because the catheters can only stay in for 3, 4, maybe 5 days. The risk of infection start to go up. There's a risk of bowel perforation. So really we prefer the cuff catheters. And then we preferred commercially prepared dialysis solutions because, again, it decreases the risk of mistakes and infection rates. However, when resources do not permit this, then locally prepared solutions may be life-saving. And in these guidelines, we go through a detailed chart of actually how you can make PD solutions from normal saline, from Ringer's lactate, from Hartmann solution, et cetera. So the guidelines cover how you can actually make the solutions, but we prefer to get commercially prepared solutions if the cost is right and we're able to get them. The dose of dialysis, so going through the literature, we concluded that with resources permit, targeting a KTV of 3.5 provides outcomes comparable to that of daily HD. That's based on the Brazilian studies. But higher doses does not improve outcomes. But this dose may not be necessary for many patients, and that targeting a weekly KTV of 2.1 may be acceptable. And that's based on the logic which I just went through. So this is really important for how we set this up in the developing world from a cost basis. So we've developed 14 sites in the developing world. The ones in yellow shown on the left are up and running, and I'll show you the results from this in a second. The ones in pink on the right are ones where we've actually shipped supplies and the projects are about to start, and the ones in white are projects which are in the process of developing currently. So I want to give you some examples of what's happened in some of the countries because it's sort of interesting to go through. So Moshi, Tanzania is where we work with really Karen Yates, and Karen has been working in Moshi for a long time, and she's been absolutely fabulous in getting this project up and running. So to do this, we took 2 doctors and nurses from Brazil, and they were sent for 4 months of training in Brazil. Now, why Brazil? And we had to pick a country where the physicians and nurses could actually do something. So if they came to the US or Canada, they can watch, but they actually can't do things. But in Brazil, apparently, anyone can do anything, apparently. So they could actually put in catheters, the nurses could do exchanges, et cetera. So that worked out great. And then they were working with Roberto Pecoitzfio and Daniela Ponce, who've had a lot of experience with PD, and they put in lots of PD catheters. So these guys went there, they came back, they could put in cuff PD catheters. The nurses knew how to do the exchanges. And we had support from Queen's Medical Center in Kingston, Ontario, from Karen. We had a CME program in Moshi. Dr. Colonzo, who was one of the residents who had gone to Brazil, came back and then got an ISN award to train in South Africa. We helped arrange lab support so that they can measure electrolytes and things which were not available at the time. And thus far, we've treated 26 patients, 18 of whom left the hospital with recovery of renal function, 5 died in hospital, 5 who felt to have end-stage renal disease and were discharged from the hospital. The average duration of PD therapy was 11 days. So this program really worked. And here you can see in the lower left of the residents actually putting in catheters. So Dr. Colonzo, who was there actually when he went to South Africa, trained other residents on how to put in these catheters. So these are guys with no nephrology training. They learned how to put in the catheters themselves. The nurses knew how to do the PD. And the program kept running when he was away. And if the guys had problems, they would send emails or text messages to Karen or myself, and we'd give them advice on how to manage the patients. And that's just Dr. Colanzo on the upper right during our CME program, sort of talking about issues. The next successful program we set up was in Mbinga in Cameroon. This is a 270-bed hospital. It's staffed by Baptist physicians from the U.S., and they have a U.S. North American-style residency program from doctors from all over Africa. When we started, there was no dialysis available. Anyone with AKI died. We've dialyzed 27 patients in Mbinga. I mean, this shows the upper right, a patient, a child being dialyzed. The residents from the hospital are shown on the bottom, and hopefully these residents will be able to start these programs when they move on to other institutions. So this has been a very successful program. And then we tried to set up a program in Democratic Republic of the Congo, in Goma, and this has been very challenging. So we had a CME program, and shown on the upper right here. This is at Heal Africa, and the hospital is shown on the bottom there. It's an incredible institution, really. It's in the middle of this war zone, basically. A bunch of committed doctors from the Congo were there. They're actually trying to manage to take care of patients. They see a lot of AKI, a lot related to trauma and war injuries. So we did want to get the program set up. We shipped supplies to them. That's shown on the upper left now. So 2 doctors from here went to India, were trained. They've gone back. They've dialyzed a few patients, not many. One of the problems have been logistical problems in the Congo, and the Congo is a war zone. It's one of the poorest places I've ever been to, and the pictures are shown here. And working there where there are armed troops basically everywhere you go is sort of difficult to fathom, but the program is actually running, and it's been very successful. And Karen actually was very instrumental in helping get this program up and started. Part of the history of the Congo, you have to know, this is from their artworks, just this horrible history. If you go back and you read what's going on in the Congo over the last 200 years, it's just unbelievable, really, and it's very nicely captured in these classical artworks from the Eastern Congo. But not all programs are successful, and Ethiopia has been one of our big challenges. So in Ethiopia, there is no dialysis in any hospital in the country, and that applies even now. There are some small private hemodialysis facilities in Addis Ababa, and they charge $150 per treatment, which is obviously unaffordable by almost everybody, except for the very, very few. We've trained 2 nephrologists in Addis, have been trained as ISN fellows in South Africa, and we've trained nurses as well. There's an ongoing relationship with the University of Toronto and actually with Seattle, Washington as well. Jeff Pearl, I think you know, has worked in Addis as an ISN ambassador. But it's taken us over 4 years to get the government to approve the importation of PD supplies, which are free, so there's no charge. Cost them nothing. They took us 4 years to get approval. And you have to understand the history of Ethiopia to understand this. There's a real reluctance to accept outside assistance. You can't get data very well. There's very limited written records. There's this oral tradition. Even in the hospital, there was no written records. Everyone passes things on orally. But it's unique among sub-Saharan countries in having an early Christian civilization. And according to the national epic, the Ethiopians are descended from the King Solomon and the Queen of Sheba. They see themselves as heir to ancient Israel, chosen by God. They've never been conquered, and when was spared the sweep of Islam across northern Africa. So the Ethiopians, as I see it, are very resistant to outsiders coming in, telling them what to do, giving them new ideas. So getting them to approve anything has proved to be almost impossible. In any case, there are patients with AKI dying, and we can't seem to have much of an impact. I'm going to skip this. So overall now, we've dialyzed over 160 patients with AKI with acute PD. In-hospital mortality rate runs around 30%. Mean age has been 10 years, so it's mostly children. The oldest patient is 60 years old. Mean creatinine at the start of dialysis is 11.3. Mean duration of dialysis is about 13 days. Cuff catheters are used in almost everybody, either single cuff or double cuff. 98% have used commercially prepared solutions. So the results really been very good. So again, the model is you put in the catheter, they're put in by nephrologists, catheters are used basically right away with a CAPD kind of technique. Patients are lying down, they're supine, so the intra-abdominal pressure is low, and they don't leak fluid. That's the point that I want to emphasize. There is no backup hemodialysis anywhere in any of these countries, so the PD has to work or the patients are going to die, basically. And the thing works. That's the part that's interesting. Infection rates have been low. So what are the lessons I think that we can look at and take from the Saving Young Lives project? First, it's the cornerstone. The PD is the cornerstone of the new ISN 0/25 initiative and will be the key renal replacement therapy used to manage patients. But PD can be used effectively to treat AKI. These preliminary results I've shown you are really very encouraging. Nephrologists can place PD catheters successfully, and these catheters can be used right after insertion. The same things we learned from the Urgent Start PD programs for patients who show up in the ED uremic. So looking at this, I think we need to go take a look back at what we do for patients with AKI. We can look at the developing world and we can learn from them. We can, in fact, use PD for AKI. There are certain clear advantages, which I think I've talked about. It's possible, but not really shown conclusively, that there's a shorter duration of dialysis needed, which sort of makes sense if you look at the hemodynamic instability of patients undergoing frequent hemodialysis. So there are potential benefits. I think this really needs to be looked at. We are going to be looking at large numbers of patients with AKI as the population ages, and I think we need to develop strategies to manage these patients in an effective way.